Good afternoon, ladies and gentlemen. I think we'll make a start. If people could take their seats, that would be great. So welcome everybody to Staffordshire Health and Wellbeing Board, Thursday the 6th of March 2025, here in the Oak Room at County Buildings. We have a few substitutes, I know, for people this afternoon and a few apologies, and then once we've done that we'll go around the room, just a very, very quick introduction. So apologies, please.
Thank you, Chair. We've received apologies from Councillor Leona Long, Richard Harling, Bernie Brown, Ian Reid, Tim Clegg, Emily Clark and Elizabeth Disney, although she'll join us via Teams for her item.
Thank you. So does any person present have any declarations of interest? Thank you for that. So the minutes of the previous meeting have been circulated. Could I ask, is everyone happy with those for accuracy in the first instance? Yep. And are there any matters arising from those that are not on the agenda that anybody would like to raise? Okay, if I can take those as an accurate record of the meeting then, thank you. Do we have any questions from the public?
No questions received.
Okay, so no questions of the public. So we'll just go a quick round robin introducing ourselves. I'm Mark Sutton. I'm Cabinet Member for Children and Young People here at Staffordshire and Chair in the Health and Wellbeing Board. And to my left is...
Wide awake. Councillor Jeremy Pert. I'm the Cabinet Member for Health and Care at Staffordshire County Council, and I'm the Vice Chair.
Hi everybody, I'm Tilly Flanagan. I'm a lead commissioner with the public health team with the County Council as part of the Health and Care Directorate.
Hi, I'm Dr. Zafar Iqbal. I'm an Associate Medical Director at MPFD and my background is public health, but I'm here today because I've led the ICS frailty strategy.
Hi, I'm Rachel Gallio, Deputy Chief Medical Officer of the ICB.
Natasha Moody, Assistant Director of Wellbeing and Partnership, standing in for Bernie Brown today.
Anna Mather, Health Watch, Staffordshire Manager.
Gary Jones, Chief Executive Support, Staffordshire.
Chief Inspector Tim Norbury, Staffordshire Police, representing Chief Superintendent Emily Clark.
Hi, Claire McIver, Assistant Director for Public Health and Prevention here at the County Council.
Miriam Hussain, I'm here to support the Health and Wellbeing Board Governance.
Jennifer Norman, Member in Democratic Services.
Okay, thank you all for that. Just a quick note to say that I will have to go at about 3:30 to get to another commitment, but Councillor Jeremy Pert will take over the chair at that point. Okay, so we go on to the item number 2 on the agenda, which is Healthy Ageing Priority Progress Update. And we've got Tilly and Zafar here for that, so over to yourselves.
Okay, so the Healthy Ageing priority is one of 4 priorities of the Health and Wellbeing Board, and we've been asked to sort of provide an update. So this is an annual update to the board regarding sort of the priorities. And what we'd like you to consider is sort of the progress that we've made over the last 12 months. And there are some actions and some discussion that we'd like to sort of share with you. But I'll just go through the paper that you will have received. As I said, it is a priority for the Health and Wellbeing Board, and also for the Integrated Care Board. The difference with this priority is that we did actually bring jointly, Zafar and myself, a couple of years ago, we actually asked that we could have one action plan that actually worked for both the priorities of the Health and Wellbeing Board and also the ICS. And Zafar will talk a little bit about sort of the frailty strategy in a second. So suppose the important bit is why is the board have this as a priority. We know that populations change, but what we're certainly seeing in Staffordshire is the ageing population is certainly sort of growing at a greater rate. So and that's a good thing. People are living longer, but what we are really interested in is making sure that when they, as they live longer, they're actually sort of living in good health and not poor health. So that's one of the things I think the Health and Wellbeing Board had recognised and wanted to sort of ensure that we develop some work to do that. So just to sort of provide you with an update, the board has considered priorities and a number of actions on a number of occasions, but last year the board actually sort of defined sort of the areas of interest, and under sort of table 1, the priorities that were agreed last year were around 3 outcomes. Enjoy independence, the 2 priorities there were improve early diagnosis and management of dementia, reduce falls in older people. The second outcome was to lead a healthy lifestyle, and in particular the priority there was to build sort of strength and balance exercise to prevent falls and improve physical activity. And then the third outcome was planning for the future, and that was primarily focused on how we can make sure people are prepared for the fact that during later life there is more planning that they need to be aware of for security purposes, but also making sure that their life ends in a way that they want to. And I know there's been some reports only today regarding sort of how people sort of die and not the way that they would like to. So as I say, last year, so within the last 12 months, we've sort of directed our focus around those 3 priorities, and as you can appreciate, that's 12 months worth of work. Some of this work and some of those outcomes are going to take much longer than 12 months. And within that time, we have had some additional data and information come through. So we've had the Director of Public Health Annual Report. Last year, the focus was around sort of basically ageing, and the title was As Time Goes By, Ageing in Staffordshire, and I'm sure that report has been shared here with you and colleagues. And then also, more recently, we've had an update in the Joint Strategic Needs Assessment, and there was a focus around sort of ageing well. So I think since last year, there's actually been some additional and new information, which I think is worth sort of noting. So I'm just going to move on to the section about what have we done over the last year and what has the impact been. And I think it's probably fair to say, as I say, 12 months isn't a huge amount of time to make changes. So some of the impact isn't directly on those outcomes, but it is about sort of some of the work that is doing is hopefully will sort of prove later beneficial for later. So I'm going to sort of invite Safa to sort of talk through some of these actions, because actually say we've worked jointly in developing an action plan that supports the frailty strategy that Safa is leading on. So we have had sort of a joint conversation. So it's one plan working for both agendas. So I'm going to hand over to Safa so he can talk through some of this agenda.
Yeah, as you'll kind of, thank you for that, Tilly. As you'll appreciate, falls is, it's a devastating, can be devastating for the individual, also has an enormous impact on the health service, and also an enormous impact on social care as well. And so we're looking to kind of prevent falls, and it's interesting, WHO have produced a definition of a risk stratification approach towards falls. Those are people at very high risk of falls, and they're going to have recurrent falls. They've had a fall, they've had 1 or 2 falls, and they will have recurrent falls. Then there's a group of people who are at moderate risk, and there's a group of people at low risk. A lot of this is very age-related, so as soon as you get to the age of 65, you're going to have a much higher risk of falls. And above 80, it's a sort of very high risk. I think it's something like half of people above age of 80 will have a fall at some point. So it's important that we have specialist services. So one of the things we've tried to do is to expand some of our specialist services for those people at high risk of falls. But I think the real prize is if we can get the general population, the moderate and the low risk people, if we can improve their physical activity levels, if we can improve their health, so they have a reduced risk of falling, that would be a massive gain to have. And one of the really effective things that we can do is strengthen balance classes. So we need some way of actually scaling this up across the whole kind of city. We haven't quite cracked that yet, but we're looking to, well, we have tried out a few things, but we're sort of looking to scale something up across the city. In terms of the second point, 5.2, leading a healthy lifestyle, you'll appreciate that we have people with severe frailty, moderate frailty, and mild frailty. And just because people have got mild frailty doesn't mean that they're going to end up in hospital, or there's nothing we can do for them in terms of progression. There is plenty of evidence that for those people, if we target them, we can actually slow down the progression of frailty. So these are generally healthy people, but they have got indicators suggest they're mildly frail. So we've been running a digital program. I think we ran it for about 4,000 or 5,000 people, and we provided support and information and access to local services around how they can slow down their progression of frailty, and we're just evaluating that at the moment. That's 5.2. That's the staying well. And then we've also got a fantastic service, which is called the Staying Well service. That's 5.2B, which is, so these are people generally with moderate frailty, but they're still not under the NHS all the time. They're not like those people who are very ill and always and often being admitted to hospital. So these people are moderate to frail, and they will end up in the severe frailty category if we don't do anything about it. So we've been offering them an amazing service where we knock on their door, unasked. We ask them, we do an assessment, and we provide a care plan for them. I've been running that service for a few years. I think we probably get through one or two, don't know the exact numbers, but a few thousand people a year. So it's quite a large scale intervention we're offering there. I think those are the main things. We can talk about severe frailty, but I think this is more about healthy aging, so prevention rather than how we manage people in the hospital setting.
And then just a few other sort of areas, and this is where we're starting to talk about some of the roles of our partners in this agenda. As Zafar sort of touched on earlier on around the importance around physical activity for this age group, there has been a piece of work, and actually it is one of Zafar's colleagues who's sort of instigated this. So we have had Newcastle-under-Lyme Council have actually launched a exercise referral programme specifically around falls prevention. We don't have any data yet. That's still very early days, but I think it's really, really good to sort of see our partners are recognising sort of this agenda, and it's something that we're interested in. We will have conversations sort of across Staffordshire. And then as a programme that supports Staffordshire and on behalf of the County Council have been running a volunteer buddy and travel training pilot programme, and that has it's been quite early. It's still quite early days, but we're actually getting some really good traction. The purpose of this programme, it was sort of twofold. Originally, it was about how we can focus on isolation and reduce isolation. Isolation isn't just an issue about older people. It is across the whole sort of age range. However, what we were aware of, particularly sort of as one of the consequences of COVID, we were seeing that some of our population and some of the more sort of vulnerable populations weren't even going out across the threshold. So the purpose of the volunteer buddy scheme was to try and support people to get them out of the homes into lots of activities, etc. The other part of the programme is what we call travel training. That's been particularly focused on our people with sort of learning disabilities and autism. Again, it's about helping them sort of start to use, sort of get more used to sort of getting out onto local transport, etc. So that has been a pilot programme, and we have supported 78 people to date, and say we are seeing some very sort of good feedback and some fantastic stories. So that's in terms of some of the healthy ageing and sort of activity. And then the final one in terms of the work that's been progressing has been particularly around planning for the future. This is really, really important. It's something that Richard Harling is, I know it's very close to his heart, is how we can actually support people to start to think earlier about planning for the times. So to avoid that crisis situation about what are we going to do about mum and dad, what are we going to do about sort of accessing funding, etc. So it's about getting people to think earlier and to plan for how they want to sort of be cared for in the future. But, you know, also thinking about sort of I suppose, more dignity in terms of dying as well. And this fits in a lot with the work that, you know, in the past Rachel's been involved in terms of the end of life sort of agenda too. So I suppose that in terms of the work there's two things that we can talk about. Again, both of these can be sort of scaled up. It does involve a lot more partnership working, but we have a programme called Compassionate Communities that's been operating more in the south of the county, and this again has included a lot of partners, and it's actually been led sort of from MPFT colleagues. Initially, sort of ICB colleagues have sort of invested in this in the past, and then some colleagues within Support Staffordshire have basically been doing the doing and delivering, and this is certainly sort of started to gain a bit of momentum about bringing partners around the table and starting to have those difficult conversations. We've got sort of certainly momentum in Cannock, and we're starting to see that happen in South Staffordshire as well. And then under this section, the final one to just draw attention to is that the South Staffordshire Local Strategic Partnership did approach us as an organisation. It's not the oldest population across Staffordshire, but they have got one of the older populations, but they have recognised as a partnership how important sort of the healthy ageing agenda is, and held a summit where they wanted to look about, as partners, how can we actually sort of look at this agenda. And as a result, they've identified 3 key work streams. So they approached us, we've started the work there, but again, it doesn't mean it has to stop at South Staffordshire. They were being proactive, we've worked with them. If we can get sort of that traction, it is something that we can do in other parts of the county. So I suppose it's sort of, you know, so that's the last 12 months. That's the work that we've been delivering over the last 12 months. I suppose it's where do we go next in terms of this agenda. It is, say, it is one of the priorities of the board. And I think we recognise, we were probably one of the first to actually, as in Zafar and I, to think about one action plan for multiple agendas and plans. However, we both recognise there's still sort of glitches, and it's still a bit tricky sort of working systematically across Staffordshire. We have got multiple boards, multiple meetings, but so we think there's still more work to do on trying to join up some of those meetings, some of those priorities, particularly in relation to healthy ageing in terms of elderly and frail. It's probably fair to say the approach in terms of dementia has been a bit slower than some of the other agendas, but now there are 2 sort of groups that have been set up, one that covers the north and Stoke, the patch, and one in the south, the patch. So we know there needs to be more energy and more focus on that, but so that's very early days. We need to just make sure we are joining those agendas up. And then again, we've got some pockets of good work around that compassionate communities. I think we've got to get this right. I think this is about being kind to people. It's a bit about building sort of that knowledge, resilience, and having those brave conversations earlier. We've got much more to do in that space. But I think it's probably fair to say that the biggest challenge for us with this agenda is that we do have an ageing population, and that's continuing to grow. And with that does come pressure across all our systems. But I think I will be honest to say we've also found it quite challenging ourselves in terms of how we can measure what we are doing and the effectiveness. And I'm just being honest, it is quite difficult for us within this area. This programme it hasn't been new money. It hasn't been, actually, there's not a lot of money in this. It has been a bit of the pulling together the willingness of different sort of partners and organisations. So, and with that comes some of those challenges. So I think in terms of us, the next steps, I think we were probably and I say Zafar and I have had several conversations around this. From when this agenda first came as a priority for the board, it was new. Unlike probably the three priorities, there'd been a bit of work done before. They weren't necessarily new agendas for this board. So this has been quite a new agenda. I think what we as I said, we've got some new data and new information. We think it's probably a time for us to sort of do a bit of a refresh. Is our approach the right approach? To say we've had one action plan, trying to serve multiple strategies. Have we got it right? We don't, so there's probably a bit of time to look at the data, to look at how we're working, and have a bit of a rethink and a bit of a refresh, and certainly to sort of look at sort of a refreshed plan in light of any of those outcomes. And I suppose the question that we need to ask you as a board, if you are in agreement with those approaches, is how you would like to be involved in those discussions. Is it something that you actually want to be there, involved, or more actually, yes, we'd like to sort of receive regular updates and reports. So, Zafar, I don't know if there's anything else that you want to
really well,
to add.
you, Tilly.
Okay, thank you both for that. We go to opportunity for questions now, and I see the Vice Chairman's been busily writing notes. I can't believe that you don't have some questions, Jeremy.
That feels like a hospital pass, so thank you. Thank you for that presentation. I do have a couple of questions, if I may. The programmes that you've identified seem to be very geographically based. So I'm struggling slightly to see the strategic intent. And maybe there isn't a strategic intent. Maybe it's population-based, and in which case that's a fair argument. But equally, how can Mark and I and the rest of the board ensure equity of access to support? Maybe that's not the intention. So that's my first question. The second one is, if people are going out proactively, I would hope to address this issue about people not dying in the place of their choice. And 50% of our population, based on the figures with the PAC today, are dying in hospital. And I'm assuming that's not where they want to be, not in all cases, obviously. But if that's the case, are we using every opportunity to make every contact count and to have those conversations? So, how assured can the board be, and how assured are we of partners around the table that we're taking every opportunity? Because sometimes it's the voluntary sector organisation or the police or someone else who brings those conversations together. I'm not saying it should just be health and care professionals. And the third question I've got relates to cost-benefit analysis. Government talks about a shift left, prevention agenda. This does sort of fit the prevention agenda. So are we doing some cost-benefit analysis against the average population of that age to be able to say, actually, every pound invested is £10 saved, or whatever it is? Because I'm just really mindful there are some people in here who are regular A&E attenders, and it's that sort of regularity that actually, if we could break the cycle in a positive way, would be really good, beneficial for the individual.
I'm happy to pick up one as well. I think the point about geography is quite interesting because if you look at population growth, it's not uniform, and there are there's obviously going to be an increase across the board, but there are patches within Staffordshire where it's going to be much higher than other kind of areas. After saying that, I think things like falls prevention, physical activity, cardiovascular risk reduction should be across the patch, across the whole area. And some of the programs we've had have been across the whole patch, like the 4,000-5,000 and the Staying Well is pretty much across the whole area. So, and I think sometimes we get in the situation of piloting in a small area and then looking for resources to do it across the patch. So I hope that answers that question about, so our aim would be to do it across the whole area if we had the resources to do it, kind of thing.
And I think picking up on Zaffa's point, and it's a really good question. Some of the examples I gave you, it's because we've actually had partners who have come and said we would like to work with you on this agenda. So it's not that we are saying we don't want to work with others. It's we've just sort of gone with the I suppose the willing as that starting point, and it will be a bit about learning from that and actually taking it out to some of the other partnerships and the agenda. So I would concur with Zaf. There's some elements that are happening right across, but some of the additionality is where we know we've got some capacity in other partners to help us with this agenda.
Thanks. Can I just come in on that? Is that through, who is that through? Is that something like the Leaders Board and the directors fitting up the working group under the Leaders Board? Or is it through here? Is it through the Frailty Board? Who is it through?
It's been more through, it hasn't been through any boards necessarily. I mean, we've obviously got, this is a priority in terms of the Health and Wellbeing Board. It was, I think if I can give you the example of South Staffordshire, they are aware of what the Health and Wellbeing Board are doing. They saw the priorities. They could see Richard's report around age. Well, they know their population really well. They recognise that they've got an ageing population, and they came to us and said, can we do something? In fact, they invited Richard down to sort of lead a summit on healthy ageing. So it hasn't gone through any formal process, Jeremy, if that's what you're asking for. But it doesn't mean we can't do that in the future.
Yeah, I'm interested in scale.
Yeah. Okay. Do you want to pick
The issue about palliative care.
No, it's proactive.
Sorry, in terms of proactive care. So the palliative care, the sort of dying. I don't know whether Rachel, you want to.
Yeah, I'm happy to pick that up actually, because I know we've talked about place of dying and people within the system not dying always in the place that they choose. I think in terms of the healthy ageing, it's about starting that conversation and making the end of life conversation everybody's business, and really bringing that to that conversation. Just for assurance, there is a palliative and end of life care board. So things like the respect form, things like increasing the registers around palliative care. There's a lot of work going on around that wouldn't necessarily hit directly into this piece of work, but is joined up with that piece of work. Another time I'm happy to bring that back to the board if they want visibility of that. But things like digital respect and working through general practice through the likes of MPFT around the respect form, an awful lot's going on there as well. So just for assurance, that work is happening, but it might not be directly run by this piece of work. Just as an add-on, while I've got the mic on, I would just like to really support the approach here around the joined-up nature of this piece of work, because the strength will become in partners all joining together around this, and I really welcome that joint approach, and I think that's the real powerful foundations for this going forward. I think Tilly, you've already talked about being able to demonstrate the impact. I think that will start to come as this grows. And seeing how that's sort of preventing that progression into moderate and severe frailty. Frailty's on everybody's agenda, isn't it? Because that's the big piece that actually impacts on people's lives, the services, the finances, all of those elements. And this piece of work is absolutely essential around building that that work around the healthy ageing and making it become part of the agenda for all of the residents in the county. Thank you.
And the cost effectiveness is something quite dear to my heart, so I'm glad you asked that question. Because a lot of these public health programs their cost-benefit ratios are really, really good in terms of how much money you invest versus how much you get back. I think the problem, if I may say, is the NHS has always struggled around prevention. It's always been a care service, really. It talked about prevention at the outset, but it's never really invested in it. And I'm really interested in the 10-year plan the government is introducing, and it's got prevention as one of their top 3 priorities, and we're very interested to see whether additional focus and resources go into prevention.
Just one final point on that one. I mean, that again is the biggest sort of scenario in terms of cost effectiveness. It doesn't mean that we can't look at that as well. So certainly in terms of our programmes of work and things that we commission out, we will always be looking at the value for money. And we do, I'm looking at Claire now, we do actually have some opportunities within our own sort of organisation, because we've recently we've attracted some funding, haven't we, around some of that research. It's something that we could probably look to see, is there merit in actually doing a piece of work that's bespoke to our agenda, but obviously that would need sort of further work.
Thank you. A couple of comments really, so thank you, that was really useful. I think what's nice is that we're starting increasingly to have more of a dialogue that poor health and frailty isn't necessarily an inevitability of older age. And we know that we need to do more earlier to keep people healthy, encourage independence, activity, all those kind of things. Although it's also important to remember that this is all often very closely linked to the health inequities sort of agenda, and knowing that kind of the impact of frailty and ageing isn't necessarily evenly distributed across the population. So I think it would be useful if we can make sure we capture that within the refresh of the plan. I think the joint plan is essential. As Rachel said, it's made a big difference already, hasn't it, in terms of bringing that conversation together and galvanising the efforts of all the partners, rather than us shooting off and doing different things or similar things and not kind of having that collective value seen. But I think it might be sensible for us to look at a focus on maybe fewer high impact actions in the sort of next iteration of that plan. And in terms of those impact measures, although we're unlikely to be able to demonstrate, for example, something that might be 10, 15 years before we'll see the difference, we might be able to consider some sensible proxy measures that we can build into that. And then I think there's a point around the partnership landscape as well. So yes, we're making good progress and we brought this together in terms of a joint plan, but it does seem to still be quite fragmented in terms of some of those groups. And we have sort of healthy ageing sitting separately to frailty, sitting separately to dementia. So I just wonder if there maybe needs to be a conversation about whether we have one overarching healthy ageing group, board, partnership, with specific sort of programmes of work sitting underneath that maybe feeds into the Health and Wellbeing Board, or at least some kind of review of what's out there so that we know we're doing the right thing and making the best use of our time. Because I think often the same people will be on those various groups, won't they? And it might actually be that that's quite timely with the review coming up for the health and wellbeing strategy and the partnerships around this as well. So thank you, it was really useful.
Yep.
Thank you. It's a bit of a comment and a bit of a question really. So in my day job, I'm usually commander of policing in South Staffordshire. I've also held command in East Staffordshire and Stafford. And one of the things that I'm obviously part of in South Staffordshire is our Wellbeing Committee meeting, which is effectively a tactical rollout of this more strategic meeting. And that's something I haven't really been a part of or seen on the scale in other areas of our geography and business. And I think the comment really is that how beneficial that is in terms of understanding some of the messages that are rolled out from this meeting, but also working together collaboratively so that we can actually play a part in delivering these messages and supporting some of the issues we have in that part of the county in terms of transport to people with drugs issues. If we respond to an incident, we can support it. That's again the help they need there and then. So the question is, do we have these offshoot meetings on a tactical level in other parts of the county, or is this something that Staffordshire are actually just very good at and ahead of the curve?
I think there are similar ones, and Natasha may be able to sort of answer some of this, because I know there are tactical meetings from a children's perspective, aren't there, in other parts of the county. It's probably something we'd need to go and just double check. So I definitely know we hear the term vulnerability hub in some other places as well. But it wouldn't necessarily be myself that would be there. Though it tends to be sort of more operational level. So what I can do is go back and check in, particularly with sort of Ruth Martin, who's our safeguarding lead, and just check what is happening across the rest of the county. And I only brought Natasha because I'm aware that children do, and often there's a bit of a mirror in terms of what's happening. So
The vulnerability hubs do still operate, so it would be worth linking in with them, and we can provide the details for those if that's helpful.
Okay, any further, Gary?
It feels like there's a bit of a theme, I think, around the bit of disconnect between some fantastic individual programmes and projects and the strategy. I'm hearing a lot around engagement with primary care and with secondary care providers. Hear very little about what the role the acute trusts are playing in this agenda. And probably where we get the most sort of frustration, I think, around engagement in system work, NHS system work, ICS system work, is around the L and the F of ELF. So end of life, a bit different. There's some quite positive observations there, but long-term conditions and frailty, there's kind of a frustration around the impenetrability of that for the voluntary sector, to how to get genuinely involved in upstream preventative work. I don't know whether the community transformation programme is one of the places that's trying to address this strategically, and I appreciate it's, as Rachel referenced, probably the reason is because this is where such a high proportion of the demand in the system sits, so it's very hard to pause the day-to-day pressures and do the much more upstream stuff. And Zaffa referenced the hopes around the prevention plan, but it does feel like there's something missing in the strategic approach to this.
Okay, thank you for that. I've got a few questions myself, one of which has been sent in by one of the members of the board that isn't able to attend. And actually it links into a little bit of what Claire just said, and perhaps also Tim, and that's around what we're actually doing at slightly earlier age than healthy ageing, because we all get to that, and how much of prevention are we trying to do, how much of this work are we trying to do before people are anywhere near a sort of what we would term an elderly age. That's the first sort of point. The second point really is about the good work that we do in various locations that's been done. How are we trying to, and I think this has sort of already been asked, how are we trying to get that across the whole of Staffordshire, and where there's good practice in one place? And I know, South Staffs in particular have been mentioned, and they've always done quite a bit of work around well-being. I know that personally, but how do we encourage other districts and boroughs to do similar stuff, so we bring it under one sort of envelope of good practice? And then the last point really is about how do we know what we're doing or is having an impact?
You're absolutely right about the early, when you're 70, 80, it's not too late. There's a lot we can do about it, but it really should have started. I mean, some of the some of the health effects are starting to kick in when you're 40, 50, 60 years old. And you can actually slow down. There's very good evidence on what your trajectory would be like if you adopted healthy lifestyles at that point versus later on, and it's a very different trajectory. So I think it's a national question as a nation we should be asking, and what are we doing when we're 30, 40, 50, and should we be working a lot more at that age rather than right at the end, where we, that national BBC report, how much money we're spending right at the end. So it's really, I think we should be. I agree with you.
I think that point around sort of location, we've touched on that before, and I think it is something I think we've recognised and acknowledged, and it's more that can be done. I suppose what I'll just sort of remind ourselves is this. It's a bit of a slow burn, this one, but we've got to keep at this, and I think that for me is a bit, if we do look at that refresh, that's a question that we need to be asking ourselves. How do we sort of, in a sense, sort of move out the good work, the good pockets of work right across Staffordshire, but that will entail commitment from other partners. So we, it's not about Zafra and I doing this. This will entail sort of commitment from other partners to sort of get into this space as well.
So that sort of brings me on to the point about, and it's one of the recommendations, isn't it, about the refreshing the action plan, and how do partners, Health and Wellbeing Board partners, and yourself see us going forward to be able to refresh that action plan, so that it is impactful without trying to drain the whole of the ocean.
When we started this work, we actually started it with two events which were really well attended. Rachel was part of that work as well. I think Mark, you attended one of those sessions. So we could go to that style, which was say two workshop events, included lots of partners, and actually there was a lot of sort of energy in the room. That could be something we could do. It could be that we also go away, and I think Jeremy, you sort of alluded to some of that, the other strategic conversations that we may need to have to buy in some of that commitment. So we've got South Staffordshire, who have got a very clear commitment to this agenda. Is that a question that we need to raise with other leaders and chief execs across the county to see, is this something that they want to work with on? So I think there's lots of different ways that we can do this, and some of it could be through existing sort of forums and meetings. I suppose the important bit for me is how you as a board would like to be involved in those conversations moving forward. Do you want to be actively involved, or is this something where, go off and do and report back?
Okay, so on that last point of Tilly's, does anyone have any comments about involvement? And while you're thinking about it, I'll just mention that we did also have that event, didn't we, Tilly, at South Staffs, with the what they usually term their parish summit, didn't we, around this agenda, trying to get down to smaller localities about what can be done. So my personal view is whether that type of event going forward could have one of those in each district and boroughs, or something similar. But of course we need buy-in, obviously, from districts and boroughs to do that. Welcome any other thoughts and comments, and I think Jeremy's got.
Yeah, I wouldn't want to lose Gary's point, because potentially if the acute trusts are going to see a benefit, which potentially they will, maybe there is a funding stream from that, and maybe they need to, and it goes back to my business case point, and they need to be definitely engaged and with us on the journey. I know they are arguably through Rachel, but actually a seat at the table on this might be important. That's my first point. Second point is, this is a strategic intent of the board. So in my view, this should be something that the board should put some time and attention to from all partners around the table, not just you know, the ones that are presenting today. Slightly unfair, I know, but maybe the time is for us to put together an hour informally once we've seen some of the stuff coming from the districts and boroughs and from some of the other places, and then chew that around and put a corporate commitment from all the organisations around this table to it. And then at least we might actually make some real tangible difference on something which is not only a priority to us but our residents as well.
Yeah, and now that we are having those informal meetings in between these more formal in public meetings, it might be useful to have one of those set aside, perhaps to each of the priorities going forward. So, unless anyone else has got any other comments, can I thank you for the for that, and can we just go very quickly through the recommendations? And we were asked to consider the update on the progress over the last 12 months, which I think we've done. Agree to refreshing the action plan and outlining key deliverables and performance measures. And I think we've come up with some thoughts of how we could go forward doing that. And I'm looking also for commitment from partners to developing and reporting performance indicators to reflect the outcomes going forward. Is everybody happy with those recommendations? Okay, thank you very much, and thank you both for your presentation today. We'll move now swiftly on to the next item on the agenda. There's two items on the agenda regarding the Better Care Fund review. And I think what we're going to do is we'll listen to both of those and take questions before we go to the both sets of recommendations, in case we recommend something in the first one that then contradicts the second one. I'm not saying it will do, but it would. I think it would just make sense. So we'll wait for the presenters to come in.
Good afternoon, Chair. We can't hear you. Apologies, because we have joined specifically for the items. So I think that might be what you were just explaining, perhaps.
Yeah, yes, it was Elizabeth. I was just waiting for someone to come into meeting. My apologies. I was just explaining that there's two Better Care funding items, and we're going to listen to both of them before we did the recommendations. So we'll do them obviously in the order that they're on the agenda, and then the first one is the Better Care Fund review, and see, we've got Heather online who's going to present that. So over to you in your own time.
Yeah, sorry, thank you. Thank you, everybody. For those that don't know me, I'm Heather Whitehouse. I'm Head of Portfolio for Integration at the ICB. And finishing off the Better Care Fund review has been one of the first things that I've been asked to do since joining in November. So I'm just going to share a couple of slides if hopefully you'll be able to see them. So just to give you some background, we made a commitment last summer to do a line-by-line analysis of those schemes that were identified in scope of the review, to determine whether to continue, expand or cease funding on certain lines. And really the aim of the review was to make sure that we're spending money effectively together for the benefit of our population, and that there isn't any duplication or and you know, we looked at where there was potential overspend and where there were schemes that were having really good outcomes. We obviously would like to focus on those and potentially invest even more in those. So the findings from this review will be instrumental going forwards in shaping our future investments to maximise that impact to our residents and the broader system. So I'll just take you through. You'll have the granular detail in the paper that has been circulated with the papers today. In terms of what I'd like to talk you through is really some of the higher level learning and recommendations about what we found and what we want to do going forwards. Obviously, not everything was in scope. There are some services that are statutory funded via the Better Care Fund, so they weren't deemed as in scope. But you will see that there are quite a number of other services, some very small, some very big, and of higher values that were in scope. What we're recommending is that we actually review some of the remaining lines of expenditure that haven't had that deep dive over a phase 2 going into next year. We feel that's really important because it will give us a really thorough idea of where to target investments going forward and make those really sensible decisions together. We have identified a massive opportunity around reviewing and integrating our falls offer and initiatives with much more emphasis on education and prevention and proactive care. I think there's a lot more we can be doing to support care homes, and I think that will definitely be one of our priorities for next year, working together and make sure that we are providing the workforce with as much support as we can to keep people well and away from hospital. We had identified some other opportunities around specialist mental health discharge support. So there is a really good offer in Staffordshire in the south, but we want to ensure there's parity in the north of the county as well. There's more work to do on high volume or high intensity users and attenders at A&E. I think we've definitely got a lot of work to do still around discharge and discharge to assess. There will be work streams that continue to look at our offer for those schemes going into 25-26 and potentially even further. What we have identified is there is a great deal of spend on quite reactive services, and I think we all agree as system partners that we do need to invest more in proactive care and prevention, which is very much obviously in line with what NHS England are proposing, that left shift. How we do that is we'll need considering carefully. We want to evaluate some of our end-of-life pathways and some of the hospice provision across the patch. So that's another piece of work that's been identified. In terms of what we've learned from this process, we feel that we probably need to share Better Care Fund plans more widely. The Joint Commissioning Board has always been and will always be the formal governance route for anything to do with the Better Care Fund, but portfolios probably need to own and take a little bit more responsibility for their areas of expertise, and we would expect going forwards that they will, where we've identified further opportunity to look at services or schemes, they will own that as the kind of subject experts, and we'll all work together to get those outcomes. We need to ensure that this process continues to be carried out on an ongoing basis, really. We don't want schemes to just be rolled over. We want to ensure that they're effective and they're getting the outcomes that we want for people that we serve. So I've outlined some clear delegation for areas of development at the end of the paper where opportunities have been identified. We need to ensure our specifications are up to date and reviewed and shared so that usage is maximised as well. What we found in the review was that sometimes colleagues weren't always aware of a service or the breadth of it. So we want to ensure that they're being used as much as possible. I think that's probably it. There's a few lines where overspend is a concern, and we've put mitigations in, and we're working really hard to ensure that some of that is managed on certain things. And just I'm really happy to do a wider education piece to just make people aware of the Better Care Fund, the associated metrics and outcomes, and the kind of national asks regarding it. The good news is that everything that's come out of the review aligns really well with some of the community transformation work that we want to do. And you've got kind of the key cohorts there, our frailty offer, falls I've mentioned, and end of life and care homes, and really building on that neighbourhood approach. There's just some detail there about the different portfolios and the opportunities that we've identified, which I've touched on. And that is it for my slides. I don't know if Elizabeth wants to add anything before we go over to Andrew, who I think is going to talk more about our plans going into 25-26 following the review.
Just very briefly, if I may, Chair, is that okay? So I'm going to, can I just check? Yes, brilliant, thank you. So first of all, apologies, I'm not able to join the Health and Wellbeing Board in person this afternoon. Thank you for making the provision for me to be able to join online, particularly for these items. It is much appreciated. What I did want to add, I suppose, was that I think that, as Heather has described, the process, I think, has been extremely helpful for ourselves in the ICB and our colleagues in the local authority to look at our shared and joint commissioning arrangements and where we use this particular fund to make a difference to outcomes for our population. And I think, you know, the paper is specific about where we've identified opportunities to perhaps change what we commission into 25-26, and that very much has been linked into the next paper that's going to be discussed around the plans for 25-26. So I think the reviews, what I'm trying to say is I think the reviews put us into a really good position to have a refreshed focus in our plans in 25-26, and I know we're going to hear about that in a moment. And as Heather said, I think it's really important that we continue the review process on an ongoing basis, always seeking to understand the value that we have got from our commission services arrangements in terms of the outcomes and the experience for our population. Thank you.
Okay, thank you very much for that. I think. First of all, any questions specifically on that part of the presentation at all? No? Okay, in that case then, we'll just go to the next presentation from Andrew, which is item 4 on the agenda, and then we will consider the two together and the whole set of recommendations. Andrew, at your leisure, please.
Thank you, Chair, and I hope I'm not disappointing colleagues on the board by not having a set of slides, but I will contextualise the recommendations, hopefully in a way that makes sense. So I think the most important element to bring out of the previous report we've just had discussed is that these reviews that have been done have fed into the paper you see here. Clearly, there are a number of other lines that set out within this paper that are not within the review because they were out of scope, as Heather said. And obviously the paper you heard about earlier included some issues and recommendations that relate to Stoke, and obviously here we are focusing on Staffordshire. Also worth noting the timescale. So the timescale for submission of our plans this year is tight, with the ambition to do that by the 31st of March. So it has been a fairly tight process in taking the learning from those reviews and then incorporating them into this Better Care Fund plan. So just taking you through the different elements, the first is to ask you to note the additional DFG allocation which has been received for 24-25, and as I'm sure board members are aware, there is an allocation formula for how that is sorted through and sent to our colleagues in the boroughs and districts. So hopefully that makes sense. The second relates to the underspends in year, which I think I have double-checked are consistent in the report you've just read and match the ones that are here. We always set out a plan, inevitably. We then have to check what's happening in reality. There are some areas that have underspent and some that have overspent. So we are looking for permission to set the overspends against the underspends. There is a remaining element to be allocated, and we are recommending that the decision on the use of that funding is delegated to the Director of Health and Care and to the Chief Executive of the ICB. The next recommendation is to note the national policy framework and the requirements for submission, of which timescale is really important, but also to emphasise the points that my colleagues have made, that clearly there is even more of an emphasis in this year than previous to support some of those shifts that the Secretary of State has set out. Very challenging to achieve with the volume of activity there is right the way across our system, but clearly the right ambition to be as preventative as possible in the work that we do, to support people in communities where we can, and to be engaging early rather than reacting where we possibly can. But that timescale to finalise the reports and do our due diligence is certainly challenging. The request then to the board is to delegate authority to approve those final plans and the reporting to the Health and Wellbeing Chair as we do that due diligence and complete the narrative in line with the proposals we've made here. Also to delegate authority for the reporting of the BCF, which will need to continue throughout the year, to the Health and Wellbeing Board Chair. The recommendation to note the findings and recommendations of the BCF review, clearly the paper that has been discussed by my colleagues gives you that in a lot of detail. It does match into, I believe, the appendix that you've got there, although we just need to do a bit of due diligence because occasionally some of the lines are described using slightly different language, which is a little unhelpful in terms of clarity, but they are describing the same thing. We just need to make sure that we've got due diligence, so we're using the same language. But the appendix you see here incorporates the output from the reviews that you've heard about, as well as all those other additional schemes. So that leads to the recommendation G to agree that proposed expenditure. There is one other item which I know the board has previously discussed, which is specifically around the apportionment of ICB discharge funding between Staffordshire and Stoke. That's set out in the report, and we note the ICB is committed to review that, and again we would look to see the output from that as part of leading to that delegated authority to the Health and Wellbeing Board Chair to agree the final BCF plan. So in summary, the report you see here includes the output from the work that has been discussed by my colleagues, brings together all the other elements of our plan, and sets out where we believe we are in terms of our submission, that final due diligence to be done, for example, just double checking that the minimum NHS contribution matches the schemes as you've discussed. The other point I would support from my colleagues is then that is our plan, but we need to make sure we are ambitious in using our public money really well throughout the year. If we are able to see more of that movement into preventing hospital admission and preventing ill health that prevents us in having to make expenditure after the fact, that will be something that would be very welcome during the course of the year. So I support the ambition to be as proactive and as urgent as we can in making those changes where they are sensible and appropriate for the population of Staffordshire. I hope that makes sense and that gives you some context to the recommendations and how they fit with the previous report.
Andrew, thank you for that. Do we have any points, any questions, anything anyone would like to raise either on Andrew's presentation or linking in with the previous one that we had from Heather? Gary?
Thank you, Chair. I should probably declare an interest, although I'm going to make a case as to why it's a non-prejudicial one in a moment, because we are one of the voluntary sector organisations that's in receipt of some of this funding, I think, which probably comes to my point. I have not budgeted for any investment from the 1st of April because we are 17 working days away from the 1st of April, and I have no idea whether that funding is flowing through to me at that point, as do other voluntary sector providers. And reading the report, it's so complicated. I still don't know, reading the report. Now, I want to say that particularly Andrew has been very supportive in getting that scheme up and running 12 months ago, working with the voluntary sector around hospital discharge. So it's no disrespect to the people who've been trying to get that money to flow. And I really appreciate that a lot of this bureaucracy is set down centrally for you and there's not a lot you can do about it. But, you know, nobody in this room needs me to tell them that you cannot plan a proper service 17 working days ahead of when everybody would like that to be delivered. It's no different for any employer. You just can't plan, you can't recruit, you can't retain, you can't keep skills, you can't build relationships. So I don't know what the answer is, but I think we ought to have an ambition to try and do some of this. Like, I feel like we should be planning now for next year, not for the 1st of April 2025. It just seems all so last minute and goes against the kind of partnership working that we're all trying to do, really. So it's just a frustration, I guess.
Okay, Gary, thank you for noted. And what I would say before bringing the next question in is that this is certainly last year, and I think perhaps the previous year, when it's come to the Health and Wellbeing Board, it's always the final decision has always been delegated to myself to sign off, and the timings have always been quite tight. So I think Gary makes a good point about whether, you know, things can happen a little bit early. I don't know whether you can make any comment on that at all, Andrew.
I think in general terms, we'd all like our guidance around planning to come as early as possible, and then for a reasonable amount of time for local partners to shape our response before we can submit. In previous years, the Health and Wellbeing Board will know that the guidance has often come out so late that by the time we complete the planning process, we're well into the financial year. At least this year, we should be completing it before the financial year. But it's a point well made. There's a real balance between the review work that the colleagues have described and then being able to make sense of the planning conditions as they come through and put together an appropriate proposal. So I accept the point you make. And I know that those colleagues of mine who are involved in some of the national bodies do make those representations to government.
Elizabeth or Heather, would you like to make any comment on that at all?
On the question, Chair, and only to say that I would agree with Gary's points around how do we provide certainty for any of our providers further ahead. I think, and at the same time, as Andrew says, you know, the allocations and the confirmation that we were going to receive, that what we had to put into the Better Care Fund was only confirmed with ourselves and the local authority about 2 weeks ago. So it isn't really an acceptable situation. I do accept that. I think what we do know for the next year is that the nature of the Better Care Fund is going to be reviewed as part of the ongoing spending review and things like the publication of the 10-year plan. So I very much hope that we might be able to build on getting slightly further ahead this year, as Andrew's reported, and get even further ahead for next year. So I think there's opportunity for us to try and resolve some of the points that Gary makes, which I firmly accept are really difficult ones for our organisations to be having to grapple with.
Thank you for that, Elizabeth. Natasha, you had a point you wanted to make?
Yeah, so it's a minor point, but I think it's an important one to make. Most of the funding that sits in BCF isn't related to children's, it's related to adult provision. But actually, for the small number that are, it strikes me that need for an approach around prevention is really critical. So in terms of the ISIS contract, for example, we've got a large number of children that are requesting equipment. And the reason they're requesting equipment is because they're sat on waiting lists that are in excess of 2 years. So I suppose I'm just interested in how assured are we that actually overall that prevention agenda is being prioritised and will lead to a significant reduction really in some of the spend that you're seeing in that system.
Heather, are you able to?
Yeah. Thanks, Natasha. So you're right. I think some of I'm not sure exactly which 2-year wait you're alluding to, but I think I've got a suspicion, and we have to do better with those weights. The problem is that, like you've highlighted, where there's a squeeze in one area, it causes that pressure on others. So the whole thing across the board in terms of children's services, and that particularly for specialist equipment, it does need looking at. And I know that we are really keen to review all of our panel processes, whether it be for equipment, whether it be for sort of one-to-one funding or other specialist things so that aren't met by core commission services. So we are committed to doing that strategic piece, Natasha, and not just being reactive all the time, and looking at how we can invest some of this money in a more sensible way, in a more preventative way. And we would really welcome you around the table when we're having those discussions for ideas on how that, you know, of what needs to be done.
I would welcome that, Heather, and I think it's really important, because what I see at the moment is that us all making single agency decisions that are having multiple consequences really for a parent and a family's journey, which isn't good for them. So more than happy for us to be involved if we can.
Yeah, and I think the links between housing, equipment, you know, we probably need to integrate everything a little bit better as well in terms of how it's set up in the first place. So those are just some of the ideas, you know, that we've got. I hope that is a satisfactory answer for now.
Okay, thank you for that. Jeremy? Yeah.
Thanks, Chair. I welcome the additional focus on falls prevention into care homes. That's really good, positive. You know, frankly, a number of us have been talking about that for a number of years, and it'd be nice to see some action. The comments I want to address is related to paragraph 13 of Andrew's report, the Adult Social Care Discharge Grant. My understanding is there's a standard methodology from which is rolled down from NHS England. Can someone explain to me why we're not using the standard methodology rolled down from NHS England? And is the intention this year to use the standard methodology and to ensure that Staffordshire gets 72% apportionment rather than what it's currently getting?
So I'm happy to address the question, Chair, if that's okay. Jeremy, there isn't a standard methodology for the allocation. There is an allocation that's issued to ICBs where they cover more than one local authority footprint, and the allocation, you know, we've been notified of what that is for this year. What we have committed to do is have a look at what that number reflects, because it doesn't reflect the change in percentage that's in the report. So it's not that the ICB is not following a standard methodology for the allocation. We are following what's in the allocation. The challenge of making any change to the allocation is that it would need to be agreed by both health and wellbeing boards, and what that means is, in effect, that the health and wellbeing board in Stoke would have to accept less money than the Health and Wellbeing Board in Staffordshire. And I think that's probably why this has been an issue that's gone on for so long. So the commitment in the report stands in terms of a review, and we'll be able to confirm that in writing before we submit the plan for 25-26.
Thank you. And maybe what the alternative is if it's unacceptable, given that, you know, we're now 3 years into the same methodology, which still disadvantages Staffordshire, notwithstanding the points you made.
Okay. Any further points on Better Care Fund? Okay. In that case, then, I'll go back to the first paper presented by the ICB. The recommendations are there in the paper, and to summarise, they are: note the findings of the review, agree on the scheme to continue into the next financial year, support the recommendations made by the ICB, and be assured that decisions for continued funding have been agreed with the respective council cabinet and the ICB board, and delegate approval of the 25-26 BCF plans and BCF reporting to the Health and Wellbeing Chair, myself, and then note the publication of the 2025-26 National Policy Framework, requiring a draft plan by the 3rd of March, and then the final plans by the 31st of March, and then F, to commit to system-wide work to review and strengthen urgent and emergency care pathways, particularly around falls prevention, admission avoidance for the moderately to severe frail population. Are we all in agreement of those recommendations? Okay, thank you. So we'll move on then to the Better Care Fund and the recommendations there, the Better Care Plan. And they were already well summarised by Andrew earlier. So they are there in the papers, A to H. So I don't intend to go through them again because Andrew went through each one in turn. Are we in agreement with those? Yep, okay, we'll take that as is. So, okay, thank you, colleagues, for those two presentations. And then we'll move on to the next item, which is item 5 on the agenda, which is, let me just get my right piece of paper here. Yeah, item 5 is the Staffordshire and Stoke-on-Trent alcohol strategy. You can, wherever you want to, Matthew, wherever you want to sit. And perhaps you could just introduce yourself as well, because you weren't here when I went through the introductions. That would be great.
Fabulous. So shift over. Hello, so thank you very much for inviting me to speak today. My name is Matthew Misson. I'm a consultant in public health. I'm part of the Staffordshire and Stoke-on-Trent Consultant in Public Health Alliance, which is a joint initiative between the Council, ICB and University Hospital of North Midlands. But importantly, in the context of today, I'm here on behalf of a partnership group which sits underneath the Drug and Alcohol Partnership Board. And we've been working together to develop an alcohol strategy for Staffordshire and Stoke-on-Trent. So today is very much an opportunity to give a bit of context as to why, and then importantly, outline some of the content in the strategy so board members have an understanding of where the strategic focus will be going forward over the next 5 years. One of the key questions we've had repeatedly through the process of developing the strategy is why focus on alcohol exclusively? There's a recognition in parts of our population that alcohol misuse or use disorder is often present with individuals who are also experiencing drug misuse at the same time. However, when you look at the national context and our understanding of how alcohol impacts on our population, it's important to recognise that there are other groups in our population that are impacted significantly by alcohol, but will never use drugs in the course of their lifetime or use illicit drugs, I should perhaps clarify. The needs in the population are different in their distribution and also some of the impacts from alcohol-related harm. Importantly, alcohol-related impacts on the health and well-being of our population are multifaceted, and there's a number of examples within the diagram there, but I won't talk through all of them today. What is clear is nationally there has been no national alcohol strategy since 2012, but there have been subsequent kind of national plans for drug misuse. So there's an opportunity to bring a strategic focus, particularly in light of the fact that there is evidence of increasing harm from alcohol in our population, despite the fact that there's a good evidence base for treatment for alcohol being effective. In our approach, we haven't just focused on health. We've taken a broad scope reflecting the partnership that has been working on the strategy development and the harms that we see within our population. So we're very much in our approach, it's been embedded in public health approach and looks to address how alcohol impacts more widely across society in Staffordshire. We have an existing joint strategic needs assessment which provided quite a compelling case for focusing on alcohol, but to understand it in more detail, we completed a needs assessment which is very much helped us understand the current context, how alcohol is impacting on our population, how the availability of alcohol is impacting on specific communities through criminality and increased accessibility to alcohol. what has been notable is some of the engagement that we've had with social care partners and how there is a bi-directional relationship between alcohol, both increasing some need within our social care system, but also people within our social care system needing support with to protect them from developing alcohol misuse in future. Many will be familiar with some of the headlines that we see around alcohol-related admissions, increasing alcohol-related liver disease and cancer from alcohol in our population. This is anticipated to increase significantly, and as a result of that, there's an opportunity to shift our focus to different groups in the population in reflection of that. And importantly, there's a strong health economic argument for taking action on alcohol, both from a health and healthcare perspective, but also there's some incredible figures from Institute of Alcohol Studies on how alcohol impacts on society, and in Staffordshire, I believe the impact is in excess of £300 million on the kind of local economy. In working in partnership, importantly, we've had to almost collectively come around a shared vision and articulate how we aim to work together going forward. There's been real benefit in working in partnership, looking at how we combine resources and the expertise that we have available, and importantly look to strengthen the leadership and governance that we have around alcohol, in addition to existing good practice that was already there. I think one key point that I'd like to make at this point, where there are multifaceted impacts of alcohol, what has been recognised is to deliver this strategy, we will be dependent on other partners reflecting the strategic objectives in this within their own strategies, recognising that we have objectives in there, but in many cases there is a dependency on others to work in partnership with us to deliver it. And importantly, where I'd like to focus some of the narrative today is on the kind of content and objectives. We have a number of chapters within the strategy. The first, Universal Prevention, provides the narrative on how we look to shift alcohol consumption within our population, change what are normalised behaviours in relation to alcohol, and importantly, make sure that all agencies and professionals are able to have meaningful discussions with people who at this point are not consuming alcohol harmfully but may be at risk of doing so in the future. A key focus within this has been looking at building resilience in individuals, particularly children and young people who may be at risk of alcohol consumption in future. Targeted prevention very much looks at your almost identification of people with escalating or existing harmful alcohol use and how we can work across healthcare, social care, and importantly with community partners to enable people with escalating alcohol consumption to access the advice and referral where needed. In Staffordshire, we have a fantastic alcohol treatment and recovery service with STARS. There's been some real progress there in integrating drug and alcohol treatment with treatment for mental health conditions. But what has been clear in engagement is that there's a real opportunity to work in partnership at how we address some of the health needs of individuals with drug and alcohol misuse to prevent them dying from other long-term conditions, as well as address some of their social needs in terms of housing, education, finding employment, so that people can meaningfully and sustainably participate within recovery and almost prevent reversion to alcohol misuse again. Working with Police, Fire and Crime Commissioner colleagues has been critical to this work, as well as council partners, and reflecting that there's been some interesting discussions around how councils can work across trading standards, licensing, planning, to manage the accessibility of alcohol within communities. There's some quite compelling evidence around how some of our communities have significantly higher density of licensed premises and availability of alcohol there's something around how we can work in partnership to try and regulate that to make sure some communities are not swamped with alcohol. Importantly, we do focus on prevention, but where alcohol-related criminality occurs, there is a need to use criminal justice solutions to effectively address that, and also make sure that individuals in crime and justice settings with alcohol misuse are able to effectively access the treatment that they need to prevent reoffending during probation and on rehabilitation into the community. And finally, attitudinal change. In the UK, we still work to Chief Medical Officer guidelines, but increasingly the international evidence base is coming to a conclusion that there is no safe level of alcohol consumption. What has been positive to see is in our younger generations, we're seeing increased levels of absenteeism and people not consuming alcohol at all. But there is, in some of our more high-risk groups, particularly men aged 45 to 64, people in some of our more deprived communities, there's a need to look at how we, through partnership communications and engagement, look to shift societal perspectives on alcohol, so that we can hopefully in time follow a similar course to the shifts that we've seen around smoking and tobacco within the UK. We are nearing a point where we will be taking the final strategy through Drug and Alcohol Partnership Board next week. That is the agreed governance home for it. But importantly, as we move through to developing our outcomes framework and delivery plan, we will be engaging across a range of partners and also community forums to inform the kind of tangible actions that partners from across Staffordshire can deliver to effectively realise the strategic objectives. And I think at that point I've got some key points to summarise, but I think importantly the ask from ourselves today is that the board recognises the strategic objectives, supports the strategy, and crucially with a number of key partners involved in the development of the strategy, we ask that as we go forward in delivery that the board kind of supports that ongoing partnership working.
Thank you, Matthew. And for those who weren't aware, unfortunately, Councillor Sutton had a prior engagement and had to leave. So please don't take that as anything else. But can I thank you for the presentation? Can I just throw the discussion open around to members? Natasha, you look like you're indicating.
Yeah. So I've got 2 points really, and the first one largely relates to, I've seen that the strategy talks about being co-developed really with people who've got lived experience, and I just wondered what does that look like from their perspective? How did we kind of co-create this strategy working with them? And the second one really is around, the reason I asked that is because we do a lot of work in children's services around restorative practice and the importance of high support, high challenge, and sometimes when reading the strategy it felt a bit like we were getting into that space of victim blaming, and I don't feel like there was enough emphasis perhaps on actually some of the poor experiences from a person who is an alcoholic, kind of interrupting that system and actually how they might not necessarily get access to the best care and support. So whilst I understand there's an outcome in there around attitudinal change, I think it's two ways actually. It's not just about us being more aware of the impact and how we need to help people, but it is also being receptive to the fact that when people come for help, it isn't necessarily incumbent on us to judge them for their choices, but actually to support them through that, because it feels to me like we don't necessarily get a strong sense of the underlying need that starts the process rather than them just starting with, I'm just going to have a drink. I just get that sense. So I'm just interested in that, really.
So to take the first question, in terms of the engagement process undertaken, we've had expert citizens who are kind of recognised lived experience organisation within our geography. They have been a key partner and sat on all of our steering group meetings. So that is one thing that we've been keen, as well as involving other partners from Health Watch and a number of almost kind of community and voluntary organisations that are stakeholders on alcohol agenda, and even some alcohol related. We've had a fantastic support from an individual who advocates on behalf of families that have experienced fetal alcohol spectrum disorder, for example. So that is one thing that we've made sure that they are represented and have opportunity to participate. Last July, we also hosted a workshop to which a wide range of stakeholders were invited and offered opportunity to engage on what they would like to see feature within strategic objectives. The challenge that we have had is where alcohol is so ubiquitously available in society and its impacts are so multiple. The challenge is, how do you meaningfully engage everyone who is impacted on by alcohol? So there has been a dependency on some professional representatives and evidence from other engagement and qualitative insight to inform some of the objectives where I think, to be honest, we couldn't engage with everyone who's been impacted on alcohol, but we have tried as broadly as we can to engage on some of the specific priorities. On the second point, there is an emphasis on the strategy on how we as organisations and professionals reduce some of the stigma we see around harmful alcohol consumption, and in doing so make treatment for alcohol more accessible to all. There's good evidence around unmet need in the population, so around 43% of people in Staffordshire living with alcohol dependency or use disorder are not currently in treatment, and that's been one focus. Stigma isn't the sole driver of that, but what has been positive to see, and there was a STARS event earlier this week, that collective approach to how we reduce stigma and have perhaps sensitive and culturally informed discussions with people around addressing their alcohol misuse or use disorder has been one key theme. There is something in how we deliver the training to enable people to do so, but positively I think we, in doing so and looking to shift the societal narrative around alcohol and alcohol use disorder, we can look to shift some of these social norms in time. I'm very mindful these things are not often quick fixes. As we've seen with smoking, for example, it's taken decades of work to bring the shift that we've seen, but there's an opportunity to set a forward direction at this point.
Thank you. Natasha, do you want to come back? No. Okay. Does someone else want to contribute? Can I just pick up a couple of comments while people think about whether they want to put anything in? I mean, I would probably challenge the smoking was probably a price-related issue which made the step change in difference. Second point I'd make is it's easy to say that 43% of the population are not in treatment, but that does that potentially gives the wrong impression, because people have to recognise there's an issue and people have to want to do something about it, and those are two different, two big steps that individuals have to want to make. I was at the STARS launch event earlier in the week, which I thought was particularly good, because it does bring all the partners together. You know, it's a bit unfortunate in some ways the strategy doesn't recognise some of the centres of excellence. So, for example, Staffordshire is an outlier in the level of importance and support that it gives to inpatient rehabilitation services. You know, and I think, you know, when you compare that across the country, I think that is a really strong point. I've got 2 points, or 2 questions. First question is, I was surprised it wasn't a drug and alcohol strategy. So, really surprised. Everyone else, just about everywhere in the country, seems to do a drug and alcohol strategy. That doesn't mean it's right or wrong, and you've given a reason for why you've gone down that route. So, when are you going to bring a drug strategy to the table? And second of all, I thought there was a joint ICS and County Council drug and alcohol strategy. So what does this strategy bring in incremental, in increments? Because if it is similar to, why haven't we adopted a joined up version across the partnership board?
Yeah. So I should probably say at this point, so drug misuse is kind of currently outside of my professional scope, but we have developed this with police, fire and crime commissioners who are in the process of developing that joint drug and alcohol strategy, I understand. In working with them, we are looking to make sure that the narrative that we have developed around addressing alcohol harms within our local population is then mirrored within that joint drug and alcohol partnership strategy. Interestingly, I think I made the point earlier around the impacts from alcohol misuse are different, and importantly, based on some of the evidence around alcohol misuse in our population, what we are seeing is there are groups within our population that are often, that they experience this unmet need where they may not necessarily present to the services which would more traditionally address drug and alcohol harm within our population. And there has been a recognition that across NHS services, community organisation and others, there is this question on how we more effectively have discussions around alcohol to detect those that, for want of a better phrase, are flying under the radar. There's a lot of evidence around alcohol, increasing alcohol-related home from consumption at home. So there's a question on how we do that. I hope in the final kind of drug and alcohol partnership strategy, there will be the evidence of that alignment and how they support each other. And this is a model that is increasingly being adopted elsewhere in the country, recognising some of the national strategic context, the evidence of increasing alcohol harms in the population. So I'm aware Sheffield and one of the London integrated care systems have recently developed alcohol-specific strategies. So there are different needs, and it's a slightly different strategic context in which we're operating with alcohol.
Thank you. Maybe you could just come back to us with a date when we're going to see a drug strategy, or that combined drug and alcohol. And I would encourage, and we've talked about this earlier, I think. I think it was Gary, or was it Tom, talked about proliferation of strategies, and if we're not careful, we all have our own strategy which all looks slightly different, and it would be a lot easier to have a joined up combined strategy that we're all supporting and bought into, rather than a different version and variation and colour, because it adds to confusion and leads us, I think, in part to being open for criticism that we talk a lot about strategies but we spend very little time delivering the strategies. And that's not a criticism, it's just an observation in terms of, please can we try and get to that point, because that's a point we must get to. Does anyone else want to add to... Sorry, Claire.
Thank you. I was just going to sort of comment on some of those points around the decision to make this an alcohol-specific strategy. I think there's always an argument to do it either way. I think in terms of treatment services and the sort of more pointy end of some of the content within these strategies, it's probably easier to do a joint drug and alcohol approach. I think for some of the broader universal preventative type activities, the alcohol sort of context is quite different, and actually the approach, as Matthew has said, is often very similar to that was taken for tobacco over the sort of past 20-30 years. So how do we reduce the sort of availability, accessibility, attractiveness of the product, and that may be everything from kind of lobbying for new policy and legislation through to taxation and price increases and things like that just make it harder and less appealing to sort of access those things. We're a long way from any of that yet for alcohol, because the culture and the sort of environment within which we're operating is very different, and there are huge commercial interests at play as well. So all of those things are relevant and I think important as part of this, and that's nice to see captured, I think, in the sort of universal and kind of wider determinants part of this strategy, which I think is really important, and in different ways isn't always as relevant or sort of applicable to the strategy you might need for illicit drug use, for example. Albeit, as I say, when the treatment side is considered, and Tony is developing a specific treatment plan for the elements that we're responsible for commissioning as a county council, for example, that's much more easy to do kind of jointly. So we have our team's been involved in helping to shape this, haven't they, as have other partners. So I think the positive fact is that we've got this strategy now in draft. We can move forward maybe with some final tweaks and get it signed off, and then focus on that last point, which is around a delivery plan that will hopefully do some of that really meaningful delivery, because we can spend months and years developing strategies, can't we, and then they just get dusty on a virtual shelf. So that's the really important bit, I think, for me, and we just need to keep that conversation, keep the momentum going.
Thank you. Really useful. Thanks, Claire. Does anyone else want to come in on this? And in which case, we've been asked, I'm going to have to flick through my notes to know what the recommendations were. The recommendations were to endorse the Staffordshire and Stoke-on-Trent alcohol strategy that will be delivered by the Drug and Alcohol Partnership led by the Commissioner's Office. And second of all, to support the continuation of partnership working to enable effective delivery of the strategy deliverables and stakeholder organisations represented at board contributing to delivery. Are we in favour of those? I think we are. That's good. Matthew, thank you for your contribution this afternoon. That brings us swiftly on. I'm going to try and recover a bit of time to the Right Care, Right Person update. We've got Lisa with us. Welcome.
Thank you.
And we'll hand over directly to you.
Okay. I will try and get you some time back, because I'm conscious that, so probably about 10 minutes, hopefully. So thank you for inviting me. My last time, as I am nearing the end of my service. So Right Care, Right Person. So I'm going to provide you just an overview around Right Care, Right Person implementation over the last 12 to 18 months and some of the work that we'll carry on in that partnership agenda. So as you know, Right Care, Right Person has been a project of work that has been implemented over the last 12 to 18 months. Let me just move this on. Oh, too far now. There you go. That's been delivered over the last 12 to 18 months, involving all our partners across that strategic network, so involving the ambulance, health, social care and acute trusts and social services. And those partnerships have been key to implementation, which aims to provide the best care to the public by ensuring the most appropriate response to calls for service. The project in Staffordshire Police has been delivered over those last 12 to 18 months through a project that's been led by the ACC as the sponsor for Right Care, Right Person. And it's obviously had a comprehensive project plan behind it, a lot of team collaboration, lots of managing risks along the way and risk mitigation, and regular monitoring communication, both internally and externally through our partnerships. We've had many tactical meetings and strategic meetings with terms of reference that have applied to work through the implementation. So the deliverables have been completed in that phased approach, so 4 phases of approach which has been welcomed across the whole strategic partnership agenda. Lots of stakeholder engagement along the way. Knowledge transfer and training has been key to it, both internally in force with our control room staff and also across that partnership agenda as well. The benefits have been monitored both internally and externally around whether what it's delivering on those implementation plans. And we've also got some work going on that I've mentioned previously at previous boards around the work that is kicking off in April with the Staffordshire Centre for Data Analytics around where we are signposting people to other services if they've actually connected with those services, and some of the picking up on some of that lived experience as well around that. Audits and quality checks have been integral to the work, so both internal audits and applying some principles with our mental health scrutiny panel that meets every quarter. That is a very partnership-led board as well. We have seen, whilst Right Care, Right Person was never about demand reduction, we have seen a reduction in police workload and productivity, and that time has enabled us to key to our core policing duties, and responsiveness to calls for service has improved as well. Again, recognising that improved collaboration with partners, so we did have strong partnerships before, they're even stronger now with that work that we've done through implementation as well. So just touching on, and I'll take you through this slide quite quickly. So it's been, Right Care, Right Person has been a large priority project for Staffordshire Police and has absolutely contributed to the wider force policing plan, and that will continue. The training, design, delivery and rollout was key to this in terms of our training for our control room staff, who are those staff that risk assess those calls for services that come into the organisation. That's improved the decision making. We've now got better resource allocation around where we are responding to Right Care, Right Person concern for welfare incidents. We're responding to those in a much better, more informed service. Enhanced public safety, so the output of that is that we're responding to those critical incidents, those grade 1 incidents where there's immediate risk to life, is improving as well. Increased confidence and that repeats it, so increased confidence in the service, which is measured through our audit and compliance as well. And I've mentioned it previously, that improved collaboration between agencies. So we're picking up on a piece of training or improvement that needs to be a partnership-led approach. We're looking at improving that through the scrutiny panel as well. So just touching on the next step. So as much as the implementation and the project is drawing to a close and we're going into business as usual now, the Right Care, Right Person activity is absolutely carrying on across that partnership network. So health partners, allowing that better understanding of the work with other agencies as well, has enabled us to apply much more scrutiny to understand that day-to-day work of both frontline policing as well as across the health as well. There are a number of ongoing work streams and opportunities that are closely aligned to phase 3 and 4. So phase 3 and 4 is much about that whole mental health activity across policing and particularly around our partners as well. We are currently, and this is health-led, there's a review of the current mental health street triage provision that, and that looks like we're moving to more of a 24/7 community street triage approach, and that is very much work that is kicking off with health as we speak. We are coming together on the 14th of March with our partners from the 2 trusts and the ICB to talk about that in a bit more detail as well. The ambition to meet the 1-hour handover times where we detain somebody under 136 mental health. We've got a really good, the target time for the ambulance service to respond to transport that person is average about 36 minutes at the moment. There are some outliers around that, and the challenges around when we do detain and they go to a place of safety. It mirrors kind of those national challenges around mental health beds as well. So that's work that is being picked up nationally as well as locally as well. And then just very, again, touching on future governance. So as much as the project and implementation is drawing to a close and we're moving to business as usual, there'll be some formal communication from the project sponsor going out to all our partners to talk about how we're going to ensure that the delivery of Right Care, Right Person and all that innovation work, improvement work carries on so that we are committed to delivering those best outcomes for individuals requiring care and support. And that is a very whistle-stop tour of Right Care, Right Person over the last 12 to 18 months. So can I just end by saying how grateful I am to all the key partners and the stakeholders that have helped us to get to this point. It's been well worthwhile. Thank you.
Thank you, Lisa, and I'm sure they would want to reciprocate, and thank you for the work that you've done in leading this. So what questions do we have for Lisa? I've just got one, which is, I'm assuming that you've been in regular dialogue with the county safeguarding scrutiny committee and
yes.
Through their chair, Bob Spencer. I'm assuming that they are happy with the safeguarding element.
Yes, absolutely. And again, part of that attendance includes attendance and updates at the Child Safeguarding Board and the Adult Safeguarding Board as well. Yeah.
Thank you. I'm not seeing anything else. So on the basis of trying to keep to time, there is one recommendation here, which is for us to receive the report and the update and any further that come through from the police. So leaves for me just to say thank you for the work that you've done and good luck with whatever it is that you move on to next.
Thank you very much.
That brings me on to item 7 of the agenda, which is Health and Wellbeing Board Review, Findings and Next Steps. I'm sure that Claire is going to take us on a whistle-stop tour because I'm sure many members of the board have already not only seen the papers but also were party to the discussions a couple of weeks ago. We're with you, Claire.
Thank you. So hopefully most of you are familiar with this item already, and if you're not, it's relatively non-controversial. So we had conversations last year about the board and its sort of function and scope and the practical arrangements that we have in place and various things, and there was an agreement that we wanted to do a review of how it operated. Miriam set about busying herself with 27, I think you got to, didn't you, Miriam? 27 interviews with members of the board and people who dip in and out for various reasons, maybe act as representatives for more senior staff or for their organisation. And this really is the summary of those interviews and any additional kind of desktop research that we've done over that period to understand how other health and wellbeing boards are operating, any of the good learning for places that are doing it well or differently. And really just to help us understand how we can get the most out of this time that we spend as a group, bearing in mind that we have these meetings 4 times a year and it's quite a significant chunk of our time when we get together. So just making sure we can utilise that to its best sort of opportunity, really. Miriam's also successfully secured some support from the Local Government Association to do a bit of an external review as well, so something a little more objective, I guess. But rest assured, we have shared the themes and the outputs at an aggregated level from those interviews, so that work won't be wasted and we won't be repeating that, although they may ask to speak to some individuals on slightly different topics as part of that process. And that will lead us up until the end of March, and then we will have a conversation about sort of what next in terms of that review process. The proposal when we spoke to them yesterday is that we have some kind of workshop in April for them to share their findings and to use that to sort of help guide next steps in terms of what the board wants to do. As Mark mentioned earlier, we've already initiated some small developments as part of this process just because it felt timely to do so, really. So we've already had one of the informal meetings in between, which I think was really successful, just to help us try and move along some of the content of the agenda, make sure the board's doing what it should be doing in terms of that decision making and also sort of the governance around some of the areas it's responsible for. And then there are some real practical things as well around how we hold the meetings, where we hold the meetings, the priority sort of theme lead role that we developed a couple of years ago, and the review of the strategy as well. So you can see the recommendations and the detail within paragraph 5. This is really just to bring that to the board for approval in terms of the process that's been taken to date and the recommendations for that moving forward.
Thank you for the succinctness, Claire. Gary, you look like you were going to smile and ask a question, but I won't put you on the spot. Does anyone else have any comments or thoughts in terms of we're at not quite a midway point, but we're at a junction where we can just assess whether we're on the right track and whether the board is supportive of the actions that are going on? Got a few nods. Okay, on that basis, it feels like we've been asked to note the findings of the review of the board and its operation, and second of all, to consider and approve the next steps detailed in paragraph 5. I won't read paragraph 5. Are we in favour of doing that? That's fine. I will quickly move on before we become unquorate, because that would be problematic. And that takes me to the forward plan. Miriam, I think this is with you.
Yeah, so we've got 3 items for the June meeting, which are healthy weights, priority progress updates, which is linked to the strategy, all age disability and neurodiversity strategy partnership update, and the draft pharmaceutical needs assessment. And with the draft pharmaceuticals needs assessment, there has been a paper distributed but not discussed in the meeting, but it is with the papers if anyone wants to look at the process. About what we do. Okay, thank you.
Thank you for that. So are we in favour of what's on the forward plan for June's meeting? And then we'll delegate how that runs to the chair when he's back. Okay. That's relatively easy. Miriam, thank you for your work on that and for leading the review of the board. That's been helpful. That just takes me on to a couple of things I just want to pick up. One is within the information items. Miriam's already mentioned the pharmaceutical needs assessment. We've not really talked about the quarterly data. I do think at some stage it'd be good for us to look at the quarterly data, just ask ourselves as part of the review of the board, you know, which bits are we going to focus in on based on the strategy, and equally which ones are we influencing the outcomes of, because I think a fewer number might help us focus on actually making some tangible differences. And I think the second thing we just want to think about is, you know, if we were going to give a review at the end of each year, what have we actually achieved? And so something which is tangible would be quite useful, and that fits that numbers point I've just made here, because I think it may help us focus on actions that deliver benefits that we want to see as combined organisations. I've got nothing else I really feel that we need to add. Does anyone else want to add anything to proceedings this afternoon? I am seeing no one indicating, so on that basis, I can give you 3 minutes back and counting. Have a good afternoon. Thank you for attending. It's really important that as partners we attend, and maybe you can carry that message to some of the people that have got empty seats here today. But equally, we should thank you for your attendance and input to today's meeting. Otherwise, we will not get the partnership working that we all so desperately want to see. Thank you. Have a good afternoon.